For a very long time, the guiding philosophy behind cancer surgery was, well, it was undeniably brutal.
Oh, absolutely. The prevailing strategy was basically maximum physical intervention.
Right. You find a mass, you surgically remove as much tissue from that area as humanly possible, and then you just kind of rely on hope.
Hope that you cleared every last microscopic trace.
Yeah, exactly.
I mean, the field was relying on an anatomical solution to what we now understand is a profoundly biological problem. We were treating the physical location of the disease rather than the actual mechanics driving it.
Which is why today we're taking you on a deep dive into a document that completely shatters that old anatomical approach.
Hmm.
We're analyzing the freshly updated ESMO Clinical Practice Guideline, that's the European Society for Medical Oncology, specifically looking at early and locally advanced non-small cell lung cancer.
And just for context, this guideline functions as the master playbook for oncologists all over the world. It synthesizes, honestly, thousands of hours of clinical trial data to establish the absolute standard of care today.
So our mission for this deep dive is to guide you through this monumental paradigm shift. Because we are officially leaving that era of blunt force and entering an age of hyper-personalized precision medicine.
It's a completely different world now.
It really is. We're
Yeah.
talking about mapping molecular blueprints, coordinating targeted immune strikes, and perhaps most surprisingly, exercising rigorous surgical restraint.
Okay, let's unpack this, because to really grasp how we treat the disease today, we first have to examine how the demographics and screening protocols are fundamentally shifting.
Right, because the sheer scale of the challenge is still staggering. I mean, over 2.2 million people are diagnosed with lung cancer every single year globally.
Wow.
Yeah, resulting in more than 1.8 million deaths. It firmly holds its position as the leading cause of cancer-related mortality worldwide.
And obviously, tobacco exposure remains the dominant cause, responsible for roughly 90% of cases. But reading through the ESMO data, there's this prominent genetic component that completely upends our traditional assumptions about who is at risk.
Yeah, that part is really striking. All right, a recent U.S. study cited in these guidelines reveals that roughly 15% of patients with lung cancer harbor pathogenic germline variants. We're talking about inherited genetic mutations in genes like BRCA2, EGFR, and TP53.
What's fascinating there is how that genetic reality forces us to reevaluate who actually requires screening. I mean, we usually associate BRCA variants almost exclusively with breast or ovarian cancers.
Exactly.
But these mutations fundamentally impair the body's DNA repair mechanisms. So when those mechanisms fail, lung tissue becomes highly susceptible to malignant transformation, regardless of whether that patient has ever even encountered tobacco smoke.
Which brings us directly to the screening dilemma. The clinical data on catching this early is phenomenal, but human behavior is, well, it's lagging far behind the science.
As it often does.
Yeah, the guidelines highlight these massive definitive studies like the NLST and the Nelson trials. And they prove conclusively that utilizing low-dose CT scans, LDCT, to screen high-risk populations reduces lung cancer mortality by 20% or more.
And you have to realize a 20% reduction in mortality at a population level is a staggering achievement for any diagnostic tool.
Huge.
These low-dose CTs are sensitive enough to catch nodules that are just millimeters in size long before a patient develops any clinical symptoms like, a persistent cough or weight loss.
Yet I found a statistic in the supporting data that is deeply frustrating.
Yeah.
In the U.S., low-dose CT screening for eligible high-risk patients is publicly reimbursed.
It's fully paid for.
Exactly. It's fully paid for. And despite that, the uptake rate is sitting at a dismal 16%. I was thinking about this, and it's basically the equivalent of driving down the highway with your check engine light flashing bright red, possessing a prepaid voucher for a mechanic right there in your glove box, and 84% of drivers are just turning up the radio and ignoring the dashboard.
That is a perfect analogy, and this raises an important question. How do public health systems actually identify and motivate the individuals who stand to benefit the most, especially when the parameters of who is at risk are actively evolving?
Right, because of the genetic factor.
Exactly. The guidelines draw attention to the talent study conducted in Taiwan, which focused exclusively on screening never smokers who just possess other risk factors, like a family history or significant environmental exposure.
And the results of that talent study showed a lung cancer detection rate of 2.6% among participants who had never touched a cigarette in their lives.
It's wild.
We clearly have to broaden our mental model of this disease. But okay, let's follow the clinical pathway. Suppose a patient does get the scan, and the radiologist flags a suspicious nodule. Under the old paradigm, the immediate next step was just booking an operating room.
Yep. Get it out immediately.
But the updated guidelines expressly forbid that kind of immediate surgical reaction. The mandate now is that you must secure a detailed biological fingerprint first.
Because the 2021 World Health Organization classification completely transformed the pathological requirements. Looking at cellular morphology under a microscope, just seeing if the cells are squamous or adenocarcinoma, that's merely the first step now. For any patient presenting with stage IB to stage 3 non-small cell lung cancer, the tumor must undergo rigorous biomarker testing before any treatment path is even authorized.
And we are specifically looking for actionable genetic alterations here. So things like EGFR mutations, ALK rearrangements, and evaluating the expression levels of the PD-L1 protein.
Because the underlying biology dictates the entire therapeutic strategy. For instance, an EGFR mutation acts like a stuck accelerator pedal within the cell, right? It's constantly signaling the cell to divide and multiply.
Okay.
So if we identify that specific mutation, we can deploy targeted tyrosine kinase inhibitors that act as a highly specific brake for that exact pathway.
That makes sense.
And similarly, PD-L1 is essentially a cloaking device the tumor uses to evade the immune system. Measuring its expression tells us if administering immunotherapy to basically strip away that cloak will be effective.
Now, reading about this molecular profiling led me to the sections discussing circulating tumor DNA, or ctDNA, the liquid biopsy.
Ah, yes.
This concept is incredible to me. The ability to detect microscopic fragments of mutated tumor DNA circulating in just a simple blood draw. But I have to push back a little on the clinical application based on what the ESMO text actually says.
Okay, let's hear it.
If we possess this highly sensitive technology to evaluate minimal residual disease, why aren't oncologists using a clear blood test today to just, cancel a grueling round of chemotherapy? Or perhaps bypass surgery altogether?
Yeah, the theoretical appeal of de-escalating treatment based on a clean blood test is immense. I mean, everybody wants that. However, the guidelines are remarkably rigid on this point, and it's due to the current mechanical limitations of the assays.
Really?
Yeah. The primary hurdle right now is suboptimal sensitivity, which generates a significant rate of false negatives.
Oh, I see. So relying on the current assays is almost like trying to find a specific suspect by only searching their curbside trash.
Yeah.
If they didn't throw anything away that particular day, your search turns up completely empty, but the suspect is still sitting comfortably inside the house.
That perfectly captures the biological mechanism at play. A tumor might be present in the pulmonary tissue, but it's just not actively shedding enough DNA fragments into the bloodstream to cross the detection threshold of our current equipment.
Wow, okay.
So while the data definitely shows a strong correlation between clearing ctDNA and having a major pathological response, trusting a false negative outside of a tightly controlled clinical trial is simply too dangerous. Moving prematurely on incomplete diagnostic tech can allow micrometastatic disease to flourish unchecked.
So we still need the physical evidence. We need the full clinical picture.
Absolutely.
So once the multidisciplinary team has reviewed the scan, confirmed the pathology, and mapped those molecular biomarkers, the focus shifts to local treatment, physically removing the primary tumor. And this is where we see the concept of more is not always better truly take hold in the surgical suite.
Right, because for over 3 decades, the absolute gold standard for resecting early-stage lung cancer was the lobectomy.
Taking the whole thing.
Right, existing the entire anatomical lobe containing the tumor alongside the regional lymph nodes, which obviously results in a significant reduction in the patient's overall lung capacity.
But the ESMO guidelines leverage 2 massive defining trials, GLGB 140503 and JCOG 00802, to completely rewrite that standard for specific patients.
Yes.
These trials focused on patients presenting with peripheral tumors measuring 2 centimeters or less. For those specific smaller nodules, the data proved that a sublobar resection, so removing just the immediate anatomical segment, or a localized wedge, yields non-inferior survival outcomes compared to taking the entire lobe.
And the clinical significance of preserving that healthy lung tissue cannot be overstated. I mean, it drastically improves the patient's postoperative quality of life and their physiological resilience. Furthermore, the guidelines mandate that these resections should utilize minimally invasive techniques whenever feasible. So we are seeing a widespread adoption of ESAS, which is video-assisted thoracoscopic surgery, and R8's robotic-assisted platforms.
Which is amazing. Utilizing small incisions, high-definition cameras, and precise robotic articulation translates directly to reduced trauma, lower complication rates, and much faster recovery times for the patient.
Totally.
And for those patients who are medically inoperable, say their cardiovascular health is just too fragile to survive, general anesthesia, stereotactic body radiotherapy, or SBRT, is deployed. SBRT uses highly concentrated converging beams of radiation to ablate the tumor with sub-millimeter accuracy, achieving local control rates of 90% or higher.
The technological advancement in local control is truly remarkable. However, controlling the primary site is really only one fraction of the battle.
Here's where it gets really interesting. When you look at the post-surgical protocols, intuition suggests that once a surgeon removes the primary mass, it would be highly logical to just apply radiation to the surgical bed.
Right, like a cleanup.
Yeah,
Hmm.
a post-operative localized sweep to obliterate any microscopic cellular remnants hiding in the margins seems like the ultimate insurance policy.
And that exact logic drove the widespread use of post-operative radiotherapy, known as PORT, for years. Physicians assumed that sterilizing the surgical margins with radiation would naturally translate to improved long-term survival,
Sure.
but the ESMO guidelines completely dismantle that assumption by pointing to the randomized lung RT trial.
Yeah, I was looking at the lung RT trial data, and the results completely defied my expectations. They studied patients who had their tumors completely resected, but had confirmed cancer involvement in their mediastinal lymph nodes. Giving postoperative radiation to these patients yielded a 47% disease-free survival rate at the 3-year mark. But the control group, who received NO postoperative radiation, sat at a 44% disease-free survival rate.
Barely a difference.
Right. Statistically speaking, adding the radiation provided zero meaningful benefit to keeping the cancer away.
And when a treatment offers no statistical survival benefit, the clinical focus immediately pivots to the toxicity profile. And the lung RT trial exposed severe, unacceptable harm. The radiation group experienced significantly higher rates of grade 3 and 4 toxicity, primarily manifesting as cardiopulmonary damage.
The documentation actually highlights severe pneumonitis and, tragically, 3 treatment-related deaths directly attributed to the radiation therapy.
Because when you expose the post-surgical pulmonary bed to high-dose radiation, you induce severe inflammation in the remaining healthy tissue, leading to fibrotic scarring. The lungs lose their elasticity, drastically impairing oxygen exchange.
Wow.
The lung RT data is a profound reminder that biological systems are deeply complex, and layering on aggressive treatments based on anatomical assumptions often accelerates the patient's decline rather than preventing recurrence.
It is a critical lesson in medical restraint. But the core problem remains, right? Even with these highly precise surgical and radiotherapeutic techniques, the guidelines indicate that 25% to 50% of early-stage patients will eventually experience a systemic relapse.
Exactly, because the local presence of a tumor is often accompanied by microscopic dissemination. Cells have likely already utilized the vascular or lymphatic systems to migrate elsewhere in the body long before the primary tumor is physically excised.
And this biological reality drives the systemic revolution outlined in the ESMO update. We're looking at a massive shift toward neoadjuvant and perioperative systemic therapies, the sandwich strategy.
Right.
Neoadjuvant refers to administering systemic treatment before the surgery, adjuvant means after, and perioperative utilizes both phases to essentially blanket the surgical intervention.
And the introduction of immune checkpoint inhibitors, or ICIs, into the neoadjuvant setting has produced unprecedented data. The CheckMate 816 trial is a prime example of this.
Okay, tell me about that.
So patients with resectable tumors were given standard platinum-based chemotherapy combined with nivolumab, an immunotherapy agent, prior to their operations.
Historically, utilizing chemotherapy alone in that neoadjuvant window resulted in a pathological complete response rate of roughly 2.2%, right? Meaning when the surgeon finally removed the tissue, they found 0 viable cancer cells in only 2% of cases.
Yes, very low.
But adding nivolumab in CheckMate 816 caused that complete response rate to skyrocket to 24%.
A nearly 12-fold increase in eradicating the viable tumor before the scalpel even touches the patient. The synergistic mechanism between the chemotherapy and the immunotherapy is the key driver of this success.
I was trying to conceptualize how these two therapies compound each other, and it feels a bit like laying siege to a heavily fortified compound.
Oh, I like this.
The traditional approach was just sending the surgical team in to breach the walls cold. It's highly traumatic, and some targets inevitably scatter and escape. But utilizing neoadjuvant chemoimmunotherapy is akin to sending in a specialized strike team first. The chemotherapy acts as the explosives, breaking down the fortress walls and causing massive damage. Meanwhile, the immunotherapy is actively distributing photographs of the enemy combatants to the immune system, training your T cells exactly who to hunt down in all the chaos.
The biological translation of that analogy is spot on. Chemotherapy induces cellular apoptosis. It forces the cancer cells to die and burst open, spilling their unique proteins or tumor antigens into the surrounding environment.
Okay.
By administering immunotherapy simultaneously, you are removing the inhibitory brakes on the patient's T cells precisely when they are exposed to this massive flood of newly released tumor antigens.
Wow.
You are essentially generating a robust, personalized vaccine effect right there in vivo. Once the surgeon removes the primary mass, those highly educated memory T cells continue to patrol the peripheral bloodstream, hunting down any micrometastatic cells that attempt to seed new tumors.
That is incredible. And this foundational strategy is echoed across multiple trials detailed in the guidelines. We see Keynote 671 utilizing pembrolizumab and the aging trial deploying durvalumab in the perioperative setting, both demonstrating profound improvements in event-free survival.
Yes.
But the guidelines also emphasize that we cannot rely solely on immunotherapy, especially when specific biomarkers are present.
Absolutely. The systemic strategy must align perfectly with the molecular fingerprint we discussed earlier. If a patient harbors an EGFR mutation, unleashing the immune system is generally ineffective and often highly toxic.
Right.
Instead, the guidelines lean on the ADAIRA trial, which proves that administering the targeted tyrosine kinase inhibitor osimertinib for up to 3 years after surgery dramatically curtails recurrence. And the ALINA trial demonstrates a similar massive survival benefit using alectinib for tumors driven by ALK rearrangements.
So what does this all mean for the operational reality of a hospital?
If we connect this to the bigger picture, it necessitates a complete restructuring of the clinical workflow. The days of a pulmonologist diagnosing a mass and directly referring the patient to a thoracic surgeon, those days are definitively over.
Yeah.
The ESMO guidelines explicitly mandate the formation of a multidisciplinary team, or MDT.
You essentially need a specialized war council. The thoracic surgeon, the medical oncologist, the radiation oncologist, the pathologist, and the radiologist must all review the molecular data collectively. They have to carefully choreograph the sequencing of these targeted therapies and immunotherapies before a single therapeutic decision is executed.
The sheer complexity of these overlapping treatment modalities requires total alignment. But, the expertise of the MDT is truly tested when they review the scans, analyze the biological data, and determine that the primary tumor is inextricably bound to vital structures. Perhaps it's wrapping around the aorta or deeply invading the mediastinum.
Which plunges us into the stage 3 dilemma. The disease hasn't metastasized to distant organs like the brain or liver, preventing a stage 4 classification, but the surgeon simply cannot safely extract the mass.
Exactly.
For this unresectable population, the established standard of care shifts entirely to concurrent chemoradiotherapy, or CRT.
The administration of chemotherapy and high-dose radiation simultaneously is incredibly taxing on the human body, but it remains the most effective local control mechanism for unresectable disease. The guidelines, however, are exceptionally firm regarding the dosimetric limits of the radiation. They cap the standard dosage at 60 gray.
See, the intuitive leap for a patient would be to ask for the maximum possible radiation if the tumor cannot be cut out. Like, why hold back at 60 gray? If you can't cut it, burn it, right?
Right, but the RTOG 0617 trial specifically tested that aggressive hypothesis by escalating the radiation dose up to 74 gray. And the trial revealed a counterintuitive and sobering reality. The higher dose actively suppressed overall survival.
Suppressed it.
Yes. The mechanism behind the failure was severe collateral damage. Pumping 74 gray into the central chest cavity caused catastrophic damage to the endothelial cells of the surrounding heart tissue and major vessels, which drove a significant spike in fatal cardiovascular events.
Striking the delicate balance between eradicating the tumor and preserving the host is incredibly difficult. However, the guidelines highlight a massive breakthrough for these unresectable stage 3 patients driven by the Pacific trial.
Oh, the Pacific trial fundamentally altered the trajectory for this specific cohort. Patients who successfully completed their concurrent chemoradiotherapy without their disease progressing were subsequently placed on a 1-year consolidation regimen of the immunotherapy durvalumab.
And the long-term data tracking those patients is astonishing. Adding that single year of immunotherapy pushed the 5-year overall survival rate to 42.9%, compared to just 33.4% for those who only received the standard chemoradiotherapy. We're looking at a near 10% absolute improvement in survival for patients facing deeply entangled tumors.
And we see parallel breakthroughs for the biomarker-driven subsets as well. The ALARA trial evaluated patients with unresectable EGFR-mutated tumors. By administering the targeted inhibitor osimertinib following chemoradiation, the median progression-free survival expanded to an unprecedented 39.1 months.
Wow.
The placebo group, by comparison, progressed in just 5.6 months.
Stretching progression-free survival from half a year to over 3 years is a monumental clinical victory. But, buried in the Pacific trial guidelines for durvalumab is a highly specific logistical mandate. The immunotherapy consolidation must be initiated within precisely 42 days of completing the chemoradiation. Why the strict ticking clock?
That 42-day window is a strict biological imperative.
Yeah.
The high-dose radiation administered during CRT physically shatters the tumor cells, releasing a massive payload of neoantigens into the lymphatic system.
It is the localized vaccine effect we discussed earlier.
Precisely. But the immune system's heightened state of alert doesn't last indefinitely.
All right.
The inflammatory response peaks and then naturally begins to recede. By administering the PD-L1 inhibitor durvalumab within that 42-day window, you are removing the inhibitory signals from the T cells at the exact moment they are optimally primed by the radiation-induced antigen release.
I see.
If you delay initiation beyond that window, the immune response cools, the T cells return to a resting state, and the efficacy of the immunotherapy drops precipitously. Timing the intervention is just as critical as the drug itself.
And the guidelines offer a stark warning against improvising that timing or blindly combining these powerful agents.
Yeah, the text is unambiguous regarding sequential toxicity. If a patient is administered immunotherapy, which heavily activates the T cells, and the oncologist subsequently pivots to a targeted EGFR tyrosine kinase inhibitor, the overlapping mechanisms trigger an intense immune-mediated inflammatory cascade.
Which is bad.
Very bad. This often manifests as life-threatening interstitial lung disease or severe hepatic failure. The biological pathways are simply too potent to mix without rigorous trial-backed protocols.
It is a delicate, high-stakes choreography. We have navigated a massive amount of clinical data today, tracking the complete evolution of the ESMO guidelines. We explored the urgent necessity of expanding low-dose CT screening to catch the disease while it is still vulnerable. We examined the foundational shift in pathology, where mapping the tumor's genetic mutations and immune cloaking mechanisms has entirely superseded simply looking at cellular shapes.
We observed the surgical discipline replacing the old anatomical models. Thoracic surgeons are achieving superior outcomes through sublobar resections and advanced robotic platforms, preserving critical lung function.
Yeah.
And crucially, the field is abandoning obsolete, assumption-based interventions like post-operative radiation that cause profound cardiopulmonary harm.
And we broke down the systemic revolution that is redefining survival. The neoadjuvant chemoimmunotherapy strike teams drastically weakening the tumor architecture before surgery, and the incredibly precise deployment of consolidation therapies within strict biological windows for unresectable disease.
I mean, the overarching narrative of these guidelines is that clinical knowledge is only as powerful as the precision with which it is applied. We finally possess a functional map of the underlying biology.
For you listening, whether you are a clinician updating your protocols or someone trying to navigate the overwhelming reality of a new diagnosis for your family, this deep dive serves to arm you with the most critical takeaway of modern oncology. A comprehensive molecular profile and an integrated multidisciplinary team are no longer optional luxuries or secondary opinions. They are the absolute, non-negotiable baseline for treating non-small cell lung cancer today.
The standard of care demands that we understand exactly what we are fighting before a single therapeutic action is taken.
And as we close out this deep dive, I want to leave you with one final forward-looking thought. We discussed the current limitations of circulating tumor DNA earlier, how liquid biopsies possess too many false negatives to safely replace a surgical resection today. But consider the velocity of our technological advancement. The sensitivity of those assays is improving exponentially. We are rapidly approaching a reality where a simple, non-invasive blood draw won't just detect the presence of cancer years before a CT scanner can visualize a nodule. It will possess the molecular fidelity to definitively confirm the exact moment a patient's body is 100% cleared of microscopic disease.
It really forces us to envision a horizon where our mastery of molecular biology and the sheer potency of systemic targeted therapies reach such an absolute peak that the thoracic surgeon's scalpel is rendered entirely obsolete.
It is an incredible thought.
Yeah.
It's no longer a question of if we will get there, but simply how soon.